Our topic this morning is approach to thrombocytopenia in pregnancy. Quite a common condition that we deal with almost on a daily basis. So I think it's a good topic for us to revise. Dr. Moipeng will be presenting to us this morning. She's a second-year registrar.
Good morning. Thank you, Dr. Naidu. I'll be presenting approach to thrombocytopenia in pregnancy this morning. This is my outline: introduction, hematological changes in pregnancy, classification, etiology, pathophysiology, approach to diagnosis, management, and then I'll look at a conclusion. Thrombocytopenia is defined as platelet count less than 150 per microliter. It occurs in 5 to 10% of women in pregnancy or in the immediate postpartum. It is the second most prevalent disorder following anemia. Despite its frequent occurrence, there is often difficulties to diagnose and manage in pregnancy. Hematological changes in pregnancy. There's a 50% increase in plasma volume, maximum by 34 weeks gestation, and is proportional to birth weight of the baby. There's also greater increase in plasma volume than in red cell mass, and there's a fall in hemoglobin concentration, hematocrit, and red blood cell count. There's no change in the mean corpuscular volume or mean corpuscular hemoglobin concentration. There's a progressive decrease in platelet counts, though they remain within normal limits. In 5 to 10% patients, platelets may drop to 100 and between 100 and 150 by term in absence of any pathological process. Pregnancy alters the balance within the coagulation system in favor of clotting in anticipation of delivery-related blood loss. There is a hypercoagulable state. There's increase in coagulation factor 8, 9, and 10, and there's also a significant rise in fibrinogen levels by up to 50%. There's a decreased fibrinolytic activity, and anticoagulants decrease antithrombin and protein S. The classification that is based on severity and also on the number of platelets. It can be classified as mild, where you have your platelets between 100 and 150, moderate when you have your platelets between 50 and 100, severe when you have your platelets less than 50. Etiology, they can be classified as pregnancy-related and pregnancy non-related. Pregnancy-related, we have gestational thrombocytopenia, we have preeclampsia, HELP syndrome, acute fatty liver of pregnancy, antiphospholipid syndrome. Non-pregnancy-related, we have immune thrombocytopenia, thrombocytopenic purpura, hemolytic uremic syndrome, type 2B von Willebrand disease, and you have infections, HIV, malaria, hepatitis, and other viruses. Disseminated intravascular coagulation, you have drugs and medications, also nutritional, where you have your folate and B12 deficiencies, and you also have malignant hematological disorders as well. The causes of thrombocytopenia by trimester and severity. This image is showing the different causes according to their timing of onset during pregnancy, and it's also based on the severity of the thrombocytopenia. In the first trimester, ITP is the leading cause, followed by hereditary thrombocytopenia. And then in the second trimester, when platelets are above 100, gestational thrombocytopenia is the leading cause, followed by ITP as second and preeclampsia on the third place. And then in the second trimester, again, when platelets are below 100, the leading cause is ITP, followed by others. In the third trimester, if platelets are above 100, gestational thrombocytopenia is the leading cause, and preeclampsia as the second. And then when platelets are below 50, preeclampsia is the leading cause, followed by ITP and the other causes. Gestational thrombocytopenia, it's actually called incidental thrombocytopenia of pregnancy. It is the most common cause of thrombocytopenia in pregnancy. It's more often recognized late in pregnancy or near delivery, but can occur at any point. Platelets usually range between 100 and 150 per microliter. It is a diagnosis of exclusion. When platelets fall below 70, it's unlikely to be gestational thrombocytopenia, and further investigation needs to be done. It resolves fully after delivery. Epidemiology, it affects 5 to 11% of pregnant women, and it accounts for 70 to 80% of all cases of thrombocytopenia. It complicates more than 9 million pregnancies worldwide each year. A small prospective observational study found that gestational thrombocytopenia may recur in subsequent pregnancies. Its pathophysiology, the precise mechanism of thrombocytopenia is still unknown. There's numerous hypotheses have been proposed, but none provide complete explanation. There's hemodilution related to increased plasma volume and the insufficient thrombopoietin response. The reduced adenstatin activity, increased von Willebrand factor. Although there's a physiologic increase in the von Willebrand factor production in all pregnancies, this quantitative change alone is not responsible for gestational thrombocytopenia, which only occurs in 10% of pregnancies. The adenstatin protein decreases progressively in pregnancy, starting at about 12 to 16 weeks through the early postnatal period. There's also enhanced platelet consumption. In terms of diagnosis and management, patients are usually asymptomatic. There's isolated thrombocytopenia when you're doing your bloods, your FBC. There can be also a previous history of gestational thrombocytopenia. On examination, there's a normal physical examination and laboratory profile. Management is usually observation only. Preeclampsia, this is the common cause in our setting. We know that it's a hypertensive disorder with onset of hypertension after 20 weeks of gestation with proteinuria. It may be classified as preeclampsia with or without severe features. It can also present in patients with pre-existing hypertension. It is by far the most common cause of thrombocytopenia associated with evidence of thrombotic microangiopathy in pregnancy. It is a thrombotic microangiopathy characterized by schistocytes present on the peripheral smear. Epidemiology, it affects 5 to 21% of cases of thrombocytopenia. Preeclampsia affects approximately 6% of all first pregnancies and is the commonest cause of pregnancy morbidity worldwide. On its pathophysiology, pathogenesis includes both abnormal placentation and angiogenic imbalance. There's excess secretion of placentally derived angiogenic factors, soluble FMS like tyrosine kinase 1. The soluble FMS like tyrosine kinase 1 sequesters proangiogenic molecules, vascular endothelial growth factor, and placental growth factor. So there's an increased SFLT1 placental growth factor ratios as seen in preeclampsia, both at diagnosis and weeks before onset of clinical symptoms, suggesting causality. There's microangiopathic endothelial injury and activation yield platelet and fibrin thrombi throughout the microvasculature. This leads to accelerated platelets consumption. There is decreased nitric oxide production and endothelial dysfunction as a result of interaction of this with placental growth factor. In terms of diagnosis, there's elevated blood pressure with proteinuria. Investigations are FBC, UNE, LFTs, and LDH. We also do urine PCR. It's also important to differentiate preeclampsia with other thrombotic microangiopathies to guide management. Criteria for diagnosis of preeclampsia. It's important to know this. Severe features that may or may not accompany preeclampsia. You have your thrombocytopenia that is less than 100 per microliter, your elevated liver enzymes, the transaminases, specifically new onset renal impairment, pulmonary edema, new onset cerebral or visual disturbances, persistent systolic blood pressure of more or equals to 160 millimeter mercury, or diastolic blood pressure of more or equals to 110 millimeter mercury. In terms of management, delivery is the mainstay of treatment as opposed to other thrombotic microangiopathies. Timing of delivery is best directed by the obstetric team. The appropriate timing of delivery is best directed by the obstetric team who factor in mother's clinical status, gestational week, and fetal maturity. Expectant management aims to stabilize the patient medically first. If gestation is less than 34 weeks, then treatment with steroids to enhance fetal lung maturity. Patients remain at risk for sudden and severe disease progression. There's also a room for low-dose aspirin initiated at 12 to 16 weeks, and it will reduce risk in high-risk patients. HELP syndrome. It's characterized by hemolysis, elevated liver enzymes, and low platelets. It prevents with a severe microangiopathic anemia. Classification of HELP. HELP syndrome has been classified into two. There's a Tennessee classification and the Mississippi classification. The Tennessee is a strict criteria proposed by CBI. In the Mississippi triple class system, a further classification is based on the platelet count any time during the course of the disease. Class 1 and Class 2 are associated with hemolysis, while Class 3 is considered as a clinical significant transition stage or a phase which has the ability of progression. So in the Mississippi Class 1, you have your platelets that are less than 50 per microliter, and your AST or ALT will be more than 70, with your LDH more than 600. And the Class 2, you have your platelets less than 100 per microliter, but more than 50. Your AST or ALT will be more than 70, with LDH that is more than 600. The Class 3, you have your platelets less than 150, but more than 100, with an AST and ALT of more than 40 and LDH of more than 600. Pathophysiology is actually similar to that of preeclampsia. There's endothelial damage, release of tissue factor, and coagulation activation. Patient may present with or without elevated blood pressure with a HELP syndrome. It's a progressive condition and serious complications are frequent. FBC, the blood count will show anemia and thrombocytopenia. When you're doing the smear, the red cell count fragments may be seen on a smear indicating a microangiopathic process. There's increased LDH, bilirubin, and reticulocytes, and absent or decreased haptoglobin shows evidence of hemolysis. Increased liver enzymes and DIC may complicate the case. Management of HELP syndrome, same as preeclampsia, delivery is the mainstay. Serial monitoring of platelets and other blood tests may guide mode of delivery. Patients can be transfused with red cells, platelets, and coagulation factors if needed, depending on the levels of the platelets and the anemia. Antihypertensive for BP control if indicated. Most women improve soon after delivery. Acute fatty liver, there's a rapid onset of hepatic failure secondary to deficiency in 3-hydroxyl-dehydrogenase or other mitochondrial enzymes involved in fatty acid metabolism. This results in fatty infiltration of the liver. Its incidence is 1 in 5,000 to 10,000 pregnancies. It's more common with multiple gestations. Thrombocytopenia is usually mild. It ranges between 50 and 100 sometimes when it's present. We use the Swansea criteria in terms of diagnosing acute fatty liver. You need to have a presence of 6 of these criteria for acute fatty liver: vomiting, abdominal pain, polydipsia, polyuria, encephalopathy, bilirubin, hypoglycemia, uric acid, leukocytosis, liver ultrasonography, where you'll find ascites, ALT and AST, ammonia creatinine, and coagulopathy. Immune thrombocytopenic purpura. It is an acquired autoimmune disorder defined as platelets count below 100 per microliter, occur any trimester, or the diagnosis may be known prior pregnancy. It is a diagnosis of exclusion. ITP occurs in 1 per 100 to 1 per 10,000 pregnancies. It accounts for around 3% of all women who are thrombocytopenic at delivery. Most common cause of platelets below 50. The pathophysiology of immune thrombocytopenic purpura. There's increased platelet destruction by the reticuloendothelial system mediated by autoantibodies specific for platelet glycoproteins. Complex mechanism involving suppressed megakaryopoiesis, which is platelets production, and TCL mediated effects. Low levels of thrombopoietin affects platelet production, usually occurs in isolation but may be associated with other autoimmune conditions. On diagnosis of ITP, there can be a known history of ITP previously, or it might occur for the first time. There's a history of mucosal bleeding, bruising, and purpura may present in any trimester. On examination, usually examination can be normal. If platelets extremely low, there can be mucosal bleeding and purpura. Splenomegaly and lymphadenopathy are not features of ITP. If they are present, that raises suspicion of lymphoproliferative disorder, but you also have to look for them. In terms of investigations, you will do an FBC first and you'll do a peripheral smear if there's thrombocytopenia. There is no available ITP with gestational thrombocytopenia. They actually are the same at some point. It is also a diagnosis of exclusion. Management. It is a diagnosis that needs a multidisciplinary team, and the aim is to maintain adequate platelets level to prevent pregnancy, labor, and delivery complication. Close monitoring is essential. Asymptomatic patients with platelets more or equals to 30 per microliter may not require treatment till delivery. According to Carodia et al., if platelet is above 30, steroids can be started closer to delivery in order to optimize for delivery. In terms of the medical management, it's indicated if platelets falls below 20 to 30 per microliter. What we give is prednisolone 10 to 20 milligram daily with ranitidine for gastric protection or any antacid that is available at the pharmacy at the time. It's important to start at a lower dose, unlike giving a higher dose at the beginning. It can be titrated, but usual maximum is 60 milligram a day to maintain safe platelet count, ideally more than 80 per microliter by the time of delivery. The initial response is 2 to 4 days with a peak response at around 4 weeks. Possible side effects include exacerbation of hypertension, gestational diabetes, mood changes, and osteoporosis. That is why it's suggested not to start it early if patients are clinically stable to avoid these side effects. The second line is IV immunoglobulin. IV immunoglobulin is a pooled blood product. It's here in South Africa is called IV polygam. It's actually quite expensive and not readily available. So, but its dose is given twice. It's 1 gram per kilogram for 2 days. Can be used in severe thrombocytopenia when your platelets drops below 10 per microliter or if there's active bleeding. It's a safe alternative and has more rapid response than steroids. Side effects include headache and less common aseptic meningitis. It can be used in combination with steroids for more rapid response. Like I've already mentioned, the dose is 1 gram per kilogram once off, or you can give it in divided doses over 2 days. It's also important that we counsel our patient that this is a pooled blood product. They need to consent to it. The third line, platelet transfusion only if there's active or life-threatening bleeding. The other drugs that can be given are thiopurine, rituximab, and splenectomy can have a role in refractory cases. But splenectomy is rarely performed in pregnancy. This will be discussed with the hematologist if there is a need in refractory cases. In terms of labor, is very important because we know at some point our patient will go into labor. Platelets should be available if platelets are less than 50 per microliter. Discussion with anesthesia is very important. Epidural or regional anesthesia contraindicated if platelets are less than 80 per microliter. It's important also to avoid assisted delivery with forceps and cesarean section for obstetric indication only. There's a 10-fold increased risk of PPH, so active management of third stage and close monitoring is important. In terms of postnatal neonatal implication, cord blood should be obtained for FBC at delivery. If neonatal thrombocytopenia on cord blood, daily FBC should be carried out until at least day 5. If neonatal platelet less than 50, a cranial ultrasound should be performed even if neonate asymptomatic. IV immunoglobulin indicated in neonates with platelet counts below 30. Thrombocytopenic purpura. This is another condition. It's an acute life-threatening condition present with a microangiopathic hemolytic anemia. Its classical presentation is thrombocytopenia, microangiopathy, neurological dysfunction, renal dysfunction, and fever. Its incidence and epidemiology, it's a rare condition occurring in about 1 in 25,000 pregnancies. Pregnancy is a potential precipitating factor. It is more common in women than men. Its peak risk for occurrence is in the 3rd trimester and postpartum. There's a risk of relapse in subsequent pregnancies. Pathophysiology, Adam-statin deficiency. It's an enzyme that is needed to break down the ultra-large von Willebrand multimass. There's accumulation of the VWF multimass that leads to platelet-rich microthrombi, multisystemic thrombotic microangiopathy, hemolytic anemia, and end organ damage. Cause of Adam-statin deficiency is most often due to acquired autoantibody and rarely due to congenital deficiency, secondary to genetic defect. This enzyme, the Adam-statin, its deficiency results in accumulation that I had already said. And this enzyme is needed to break down the large VWF multimass. Its deficiency results in accumulation of the von Willebrand multimass, thus leading to platelet-rich microthrombi and multisystemic thrombotic microangiopathy and hemolytic anemia and end organ damage. Hence, platelet transfusions are relatively contraindicated in TTP as they may potentiate the thrombotic process. The underlying cause of the deficiency of Adam-statin is most often due to the presence of an acquired antibody. Rarely there's a congenital deficiency to a genetic defect. The two types can be differentiated by the measurement of the Adam-statin activity and inhibitors of the levels the latter being absent in the congenital form. There's a typical drift down in Adam-statin levels during the 2nd and 3rd trimester in pregnancy and normalize in the postpartum. The differential diagnosis are other conditions, preeclampsia, hemolytic uremic syndrome, and HELP. The investigations that we do for TTP is FBC with a smear, LDH, LFTs, and UNE, Adam-statin protein, which is the confirmatory test. Its management, there's a multidisciplinary approach. Plasma exchange is the main treatment with high-dose steroids given as an adjunct. Rituximab is sometimes added to improve the condition. Of note, termination of pregnancy does not induce remission of TTP, unlike HELP and preeclampsia. Platelet transfusions relatively contraindicated as they may potentiate condition. Hemolytic uremic syndrome is a microangiopathy similar to TTP, occurs mostly in the postpartum period, can present with the same pentad as TTP, though the renal dysfunction predominates. Epidemiology, it's a rare disorder occurring in 1 out of 20,000 pregnancies. In one retrospective study of 100 women with atypical hemolytic syndrome, 21 was pregnancy associated, and of this 79% occurred postpartum. Its pathophysiology, there's activation of the complement pathway leading to renal failure. There's mutation in complement regulatory proteins, mutations in complement factors B and C3, which is an atypical hemolytic uremic syndrome. And then there's also associated with an infection with Shiga toxin, producing Escherichia coli, particularly types 0157H7 and 0104H4 in the typical hemolytic uremic syndrome. Plasma exchange, although response is poorer than in TTP, with patients often developing chronic renal insufficiency, eculizumab, if poor response to plasma exchange. Eculizumab is a new therapeutic agent that can be used. It's an immunosuppressant. After discussion with a hematologist or a renal specialist, supportive treatment is important. HIV-associated thrombocytopenia. The prevalence of cytopenias have declined in recent years with modern ARV use. Unexplained thrombocytopenia is an indication for HIV testing, more so in high prevalence areas. HIV infects hematopoietic stem cells, impairing production in all hematopoietic lineage. Opportunistic infections due to HIV-induced immunosuppression can also affect developing blood cells, either directly or via cytokine upregulation. Thrombocytopenia is often mediated by autoantibodies or direct effects of HIV on the bone marrow. Initiation of antiretroviral in patients with mild to moderate thrombocytopenia who are otherwise well is often sufficient to raise the platelet count into a safe range to reduce the risk of bleeding. A general approach to a patient with thrombocytopenia in pregnancy, patient might come with a history of bleeding, symptoms past or current, headaches, a family history of bleeding or thrombocytopenia, obstetric history, previous thrombocytopenia or neonatal blood counts, infectious symptoms, also history of medications or autoimmune disorders. Approach to diagnosis in terms of physical examination, you will look at your vitals, your blood pressures and temperature. The skin, you will assess for purpura, petechiae, mucosal bleeding, conjunctival hemorrhages, rashes, lymphadenopathy, abdomen splenomegaly, hepatomegaly, any abdominal tenderness. The central nervous system, you will check for the level of consciousness, any focal neurologic deficit, seizures, and lower extremities edema. Approach to diagnosis in terms of the investigation, there will be initial investigation. In the initial investigation, you're gonna do your urine dipstick, your full blood count. If there's thrombocytopenia, you'll ask them to check if there's clumping. Then you'll do your FBC in a citrated or a heparin tube, where they can do a manual count and a peripheral smear. You do your renal function test, your liver function test, your LDH, coagulation screen, septic screen, where you're going to check for your urine MCNS, CRP, or PCT if indicated. Viral serology, where you're going to check for HIV, hepatitis, H. pylori, Parvo B19, CMV, EBV, malaria, autoimmune serology as well, ANA. For further investigation, you look for reticulocyte count, Coombs test, blood cultures, abdominal ultrasound, Adam TS13, bone marrow biopsy if indicated. In terms of management, a general consideration, timing of presentation is important when you're assessing your patient to guide you in terms of the diagnosis, severity, etiology, and it's important to know that this is a multidisciplinary approach. We need to consult if a patient comes in with thrombocytopenia. Proper investigation prior to transfusion, bleeding risk, procedural, delivery, or anesthetic. There's risk for spontaneous bleed, especially intracranial if platelets less than 10. This table, I just summarized these conditions here. It's the stuff that I've already mentioned. With gestational thrombocytopenia, the semester which is presenting that is late, the severity is mild, clinical features asymptomatic, and in terms of primary treatment is observation. With ITP, it can occur any trimester or prior pregnancy. Its severity can be mild to severe. Bleeding if platelets very low. First-line therapy, corticosteroids and IV immunoglobulin, and second-line therapies, azathioprine, cyclosporine, rituximab. Number 4, splenectomy rarely performed. The TPO thrombopoietin mimetics off-label. With preeclampsia and HELLP syndrome, they usually occurs around at 20 weeks, typically third trimester and early postpartum. In terms of primary treatment, fetal delivery, BP control, aspirin, magnesium sulfate indicated, and steroids for fetal lung maturity. With TTP, any trimester or prior pregnancy, it's a severe condition. Its main treatment is plasma exchange for acquired TTP, but fresh frozen plasma can be given for congenital TTP. With hemolytic uremic syndrome, the main treatment is it's plasma exchange, but patients do not do well with plasma exchange. So eculizumab is the drug of choice. Renal replacement therapy may be required. Conclusion, thrombocytopenia is common in pregnancy as the second cytopenia following anemia. Systematic approach is vital in identifying the etiology and guide to relevant management. Preeclampsia and HELLP syndrome are more prevalent in our setting and are causes of thrombotic microangiopathies whose definite treatment is delivery. Multidisciplinary approach is important when treating patients with thrombocytopenia. These are my references. Thank you.
Thanks, Dr. Mopeng, for that overview. Any questions?
Good morning, Dr. Raona and Dr. Mopeng. Thanks for the presentation. We requested Dr. Lungi Qiliza Mata she's the hematologist at King Edward, and I can see she's online. If she can just give us a bit of input from her side, and then we will take questions from then on. Welcome, Dr. Qili, and we appreciate the time you've taken. If you can just give us some input into this topic, thanks.
Good morning, Prof. Good morning, Dr. Knight and Dr. Mopeng. Thank you for this invitation. Thank you, Dr. Mopeng, for this talk. I think it was quite a broad topic, and it was a good overview. I'm just not sure if this is the time, but I'm not sure if this is a King Edward talk, or is it the whole province that attends, because I don't want to bore you with what might not be applicable to in terms of laboratory.
No, everything KZN applies to us. This is a talk for the registrars throughout the province.
Oh, okay. No, so I just wanted to highlight a few things, in terms of the hematologist services. So for me, I think in the labor ward, when a patient is very, very ill or very ill, you know, when you do that FBC, please do a peripheral smear, even before you call the hematologist. It's a little bit different for Albert and King Edward, and I think Grays, because the hematologists are on site. But for the peripheral hospitals, you then have to, phone and consult the registrars in the lab. So I would be one of those people. And at the moment, I know we are starting to cover Gwelezane and Queen Nandi. So you would probably you'd be put through to myself. So I just wanted, with regards to that, firstly, any sick patient, when you do that FBC, please do a peripheral smear. Another thing from our end is to say, I think at baseline, when you are seeing that when the patient is booking in, if that initial if that first FB, if that, I beg your pardon? Sorry. So if the patients can have a full FBC at booking, because when we are now 20 weeks later and we've got a thrombocytopenia, we don't really have anything to compare to and try to trace our steps back. So those are the two, I think, main things with regards to the hematology department. And then on the talk, I just wanted to highlight that with regards to treatment of ITP, we usually give 1 milligram per kilo of prednisone. In as much as it looks like a high dose, we do, when the patient starts to respond, we then start to titrate. After delivery, we would then discuss for splenectomy, which we do very commonly. And it actually controls the patients because, as Dr. Mabeng said, it's really a disease that it remits on its own if it does remit. And then with the, I think another probably, I'm not sure if it was maybe an oversight, there's antiphospholipid antibody syndrome. It's another condition that presents with thrombocytopenia in pregnancy, and it is associated with poor bed obstetric history. So that's another thing, that when you are doing those baseline bloods, you could add a coagulation screen. And if the PTT or the APTT is prolonged, you could take it forward and look for antiphospholipid antibody, so the lupus anticoagulant, just to remember that. And I think with regards to double checking that a platelet count on the titrated tube, please can I ask that, you arrange with the lab, because that sample needs to be analyzed within 15 minutes so that we get a more accurate result. So those are some of the things that I have picked up. I mean, there's always a lot to delve into deeper with probably every part of this talk, but I think those are some of the practical points that we could maybe take after this this talk. Thank you.
Thanks, Dr. Clearly, continue, Dr. Rawana.
Thanks for that. That was very helpful. From the hematology side, are there any more questions? Dr. Moran.
Thanks for the talk. In your talk, I think with ITP and TTP, you mentioned a couple of drugs, rituximab and eculizumab. Seems like there are a lot of new drugs coming out that are, sometimes recommended by the hematologists. These type of drugs that end in ab. There seems to be a new one like every month coming out. And you mentioned that they can be used, but I think in a talk like this, it's good to present the evidence. Are there any trials in these conditions? And what is the effect of giving the drug compared to giving steroids or plasma exchange, etc.? Because these drugs are very expensive. So if we're going to recommend them, it's good to have a clear idea of exactly what they add in terms of outcomes. So, you said TTP, the drug of choice is eculizumab. On what basis is it the drug of choice? Are there trials that have been done, or is it just a few case reports where it seemed to work?
I think I said the drug of choice for eculizumab, it's in hemolytic uremic syndrome because the patient actually do not do well after plasma exchange. But with TTP, when there's plasma exchange, patients do improve drastically. So the eculizumab, because it's an immunosuppressant, patients do well, but it's I did not really check for the for the evidence, but they did not mention it being teratogenic to the babies. But it's usually in discussion with the hematologist.
I'm not sure if the hematologist has anything to add on that.
Yes, so eculizumab, I know that it's usually the very last line of treatment, obviously because of cost. It is available. It's an anti-C5 monoclonal antibody. So it's actually to try and induce remission of the complement pathway disorder. I don't there is evidence, but in our setting, I don't recall it being used on a pregnant patient. We've had some patients who have had rituximab, but eculizumab has been quite difficult to get. On the few patients that have had rituximab, initially the patients respond, but inevitably after a year or two, or when we start to decrease the frequency of administration of the drugs, they tend to relapse. The rituximab is mostly used in ITP to just dampen down the antibody, so the B12 function, so the CD20 B cells function that produces the antibody that ultimately is cross-reacting with the platelets and causing the thrombocytopenia. So in the acute setting, probably there is no utility for us in our, financially restricted setting. I don't believe we've got that much experience, although the drugs are available. And also, with the TTPs, mostly when it's HIV associated, then patients tend to be given FDPs and steroids, and that tends to work. So it's been this by reason of financial constraints rather than absolute unavailability of these drugs.
Thanks for that. I think that was a bit beyond our scope as obstetricians. It is a broad topic, so we just wanted to mention all the options. It's helpful for you to put them into perspective for us. Any more questions, Dr. Nadada?
Yes, thank you for the talk. For this topic, as we said, it's probably second most common to anemia. So I would have appreciated more of a flow diagram to say, when you go out of here and then you meet a patient with thrombocytopenia, this is the first step. So you check related to hypertension or not related to hypertension. And then you know from there, then you send a sample with the sodium citrate tube, this clumping. I mean, something like that, because these are the patients that I encounter in the labor today or by next week, so that we are all clear on how we go about investigating them. Because on the investigations, we saw the same list, of which most of us are guilty of the same thing. When we see a patient with low platelets, we just send all those blood tests at the same time. Or we invite the physicians to come and the patient with us. You probably left out pools and all those things that they ask for. And then they just want everything, certain screen, this and that on a patient that clinically, there's no clinical evidence of those things. But I was hoping to get some sort of an outline to say, let's move like this, and then from there to there. It is there in the presentation, but it could have been much more simplified. Same goes for C-section and the delivery. What's the advice to the people who are attending the patient who's got thrombocytopenia and Caesar and NBD? We have to do anything different. And then, yes, we know with the Caesar, there's a few steps that we should do different. So for our colleagues, I think we could have done that. Also, a more practical approach in terms of your platelet cutoffs. When we got it there that they are less than 10 or 20, then you can transfuse them. But when you prepare for a procedure, like a simple amniocentesis, or you're preparing for an NBD, you're preparing for a Caesar, what could you use if you have a patient that is under your care in the ANC to sort of improve the platelets, like in an ITP situation? And then when do you expect to see response? And so it says bones or so. But it's things like that where I wish we could have been more practical about them. And like if the steroids, there's no response, when do you think to change to the polygam? I know the common issue with hematology, but the condition is just too common for us to still walk out without being excited here. on what to do with the very next stage. Maybe it's me alone, but I didn't get the practical side of the presentation. Thank you.
Thank you for that. Anyone else? Okay, thank you for your attendance.
Thanks to everyone and Dr. Qili.
Recording stopped.
Reminder about the campaign tomorrow for those of you that are available. Thanks.
Thank you.